Hi, everybody. This is Dr. Ed Park. Today, we'll be doing a webinar on hip injections. This is the fourth in a series. I went to Harvard undergrad and for my residency in OBGYN, Columbia for my MD and Master's of Public Health. And in 2016, I was consulting for anti-aging using exosomes. That person I brought in subsequently founded a successful exosome cosmetic business. In 2018, I heard a neurologist, now a colleague, talk about his motorcycle accident. Horrendous. He lost a third of his blood. He broke his collarbone, 9 ribs, and his ankle. So I thought, if he's telling the truth, I should try this. I did try it. It fixed my rotator cuff, my knee meniscus, and my Achilles. So I started treating patients, friends, and family. Over the last 6 years nearly, I've created a lot of blogs, a lot of videos so you can learn more. This is free to download on my website at rechargebiomedical.com. I also created an online provider training course, which is 12 hours online. All these protocols and videos appear there for your use as well. I've done at least a half a dozen on-site trainings for doctors, and we'll bring in their friends and family. We'll do the procedures, and they'll get that experience in these 6 states in which I'm currently licensed. I also wrote and narrated a book, Exosomes Songs of Healing, which you can get at Amazon. So size wise, we're looking at big organisms on the left, the hydrogen atom at like zero point 0.2 angstroms on the right. What we're talking about is cells are measured in nanometers. So, or actually microns. So they can be like 3-ish to 100. The big ovum is 100 micrometers, which is 100,000 nanometers. Whereas exosomes, as are produced in the multivesicular endosome above me, maybe 1 or 2 dozen of these little balls within a larger ball that's extruded. These are in the 100 nanometer range. So they're around 1/200th the diameter. Therefore, they don't have DNA, they don't have machinery, they don't copy themselves, they don't have mitochondria. They are not possessed of these self-identifying antigens, so you can't reject them, unlike larger cells. But thousands of studies, tens of thousands really, since they started studying them, show that things like cancer, disease states, cirrhosis, liver failure, there's all kinds of bad music playing. And then when they're healing, there's some good music. So we'll try and stay away from that good, bad, uh, and get beyond that. So why didn't people know about exosomes? Well, they did. So the electron microscopy was invented in the 30s. So for, 40, 50 years, they saw these little balls from these bigger balls being extruded, and they called it cellular poop very arbitrarily, almost as though an alien looking down at humans say, well, they make poop uh, and some urine and some carbon dioxide, and they talk and they type. But, what they're communicating is not really important. So that's kind of an insult. Like we see AI created this wonderful picture of Nikola Tesla, who had some beautiful ideas about the world and great inventions. And so to say he's just making poop and his communication doesn't matter is quite the insult and misunderstanding. So about 16, 17 years ago, they got wise and they figured, oh, they must be in the broth that the cells are growing in. So nowadays they take the stem cells, they grow them in these flasks shown above, and they throw out the bath water and filter it. So conditions like oxygen, CO2, nutrients, every few days they filter it and they find a plethora of these exosomes, which they filter by size exclusion in the manner shown in the green. So anything small enough to fall through the grates is exosomes plus. And the confusion, which was addressed last week, why do people talk about trillions of particles? Well, they don't do size inclusion, which they could. So all the tiny little things and schmutz in there, they're counting that as exosomes, which is a mistake. You can't see exosomes because they're invisible. So when I went to the ISEV, or International Society of Extracellular Vesicles, they explained that. Well, I asked the question, well, so what's in the bigger microvesicles? And they're like, well, a lot of times, to be honest, it's the same as in the tiny exosomes. So there is this inherent bias that the ones that are made in these MBBs or MBEs are special. They might not be. But what's cool about the bigger microvesicles is that they can even have mitochondria inside them. So in the tendons and the retinal pigment epithelial cells, they can share these mitochondria, like borrowing a cup of sugar from your neighbor. So this is how the cells communicate. It's not poop. So they have mRNAs, proteins, microRNAs, which are blocking RNAs. And so this is where it's at. So in the past, PRP caused inflammation, which brought in stem cells, which release exosomes. I would argue we just need the exosomes. We need the songs. We don't need the cover band. So what do? They cause stem cell proliferation, dedifferentiation, which we need in some of these burnt out, tired senescent cells, extracellular matrix and vascular regeneration. And they shift the T cells from one phenotype to Th2. They also cause the macrophages to be from inflammatory to regenerative and anti-inflammatory, or M2. So they're more powerful than the one-off protein. Why? Well, look above. The electron microscope shows that simultaneously the one message is being read by many ribosomes. Ribosomes are the machinery that read the message and pump out the protein. So the cartoon illustrates that. It's as though you had a player piano roll, but not just a one-off. It can be fed into multiple pianos at once and create multiple copies of your protein. Last week, unfortunately, a patient with a history of migraines, her nasal injection triggered a migraine. It went away, but that's still added to the adverse effects. But you see that 21 out of 25, 54, that's below standard placebo rates of complications, from saline. So just people psychosomatically get a higher rate than that. Over the last 5+ years, I've treated a lot of patients, a lot of visits, a lot of repeat patients getting other areas treated. The response rate usually 60 to 80%, depending on the situation. And you can see some of the complications shown above. One of them was a patient who had a herpes activation. She got really scared, but she does have bad OA. So I treated her last Friday in New York City. You can see hips. This number is, I think, underrepresented. I've done more hips than this, so my record keeping is not great, but it's one of the procedures I insist on using ultrasound. So as you know, all patients sign and read this consent. Dr. Park and I want to do this. No guarantee, not FDA approved, not standard of care, although it is standard of care from a natural perspective. In other words, from birth to death, your body and the bodies of every animal and perhaps even plants use exosomes to heal and recover. The FDA is currently reviewing numerous studies for indications such as infertility, long COVID, uh, and Crohn's disease. If and when they get approved, then we can use human exosomes from a newborn placental source to help mitigate our healing. We look at the studies of the Cochrane Review. There are none, but there was a review paper in 2020 looking at the use of corticosteroids for hip osteoarthritis. One showed negative results, or showed mild positive results for 3 months or less at low dose indications. But again, we have to be careful because steroids are known to cause tissue degeneration, osteoporosis, and chondrocyte toxicity, setting up for more problems in the future. So the difference between this gymnast with strong hips and the old man is about 30, 40 years. Why? Because rust never sleeps. We're always getting older. Stem cells are copying, their telomeres are shortening, they're getting mutations, they're getting epigenetic silencing. So this is happening everywhere all the time in our bodies. Consider the humble limb trap. Even though you can sew and clean your clothes, there's always something in the limb trap. That means your clothes are going away. In the same way, your stem cells are eventually all going to go away. So what is the problem? We have a weight-bearing complex. Your posture, your conformation, your repetitive stress injury causes you to use it and lose it. So injury, of course, affects us. Aging, arthritis, weakness or imbalance of the muscles, osteoporosis can cause, of course, femoral neck fractures. So I argue that the local depletion and deterioration of your stem cells is always at work in your bone, cartilage, ligaments, muscles, vessels, and nerves. So what are the hips? Well, language is fuzzy, as AI will tell you. It sometimes conflates, hallucinates, misinterprets. The hip can refer to a roof, meaning if your roof meets with this wall thing, it's a gable. If it meets with another roofy thing, it's a hipped roof. The guy in the middle is a hipster. Maybe he does beat poetry. The hips can also be bust, waist hips. The classic hourglass figure that's so attractive is shown in the odalisque with her wide hips. And why? Breasts for feeding and hips for childbearing. As an OBGYN, we like the gynecoid round female pelvic inlet. If you have a heart-shaped pelvis like a man, that's android, not as good for a smart baby. A smart baby has soft bones in its head that can fit through. But the reason why humans, before the invention of C-sections, haven't gotten to be smarter is because you got to safely bring that head through the pelvis. Although the pelvis does accommodate by opening, as we'll discuss. So one coxa is a hip and two coxae are hips. The hip is basically the three fused bones on the side of the wings of the butterfly. Number two is the ilium. Number three in moth is the ischium. And number four is the pubis. So the left hip and the right hip bone connect to the sacrum, forming the whole pelvic bowl. And this bowl separates during pregnancy because of a hormone called relaxin. And so, like an onion bloom at outback, it's opening up and it hurts. So the hips are that joint, the ball in the socket. It's also the non-axial pelvis by definition, meaning those six bones without the sacrum. It's a region. The lady next to me says, "Oh, my hips hurts." It's for you to figure out what exactly that means. And then it's also function. The hips function to stabilize the torso on that single leg and in ways that we'll discuss. So when you're in the stance phase, the hips are working to stabilize. There are six motions. You don't need to remember this. If you want it, you can learn or rewind, but we'll just do it for completeness sake. So hip flexion is the first hokey pokey. It's you put your right foot in. So if you lift your right foot like the skeleton above, then the left foot has to stabilize the body. If the left foot has weak hip flexors, that can't prevent the torso from falling backwards. So as a result, the person will lean away from that side. They'll rapidly circumduct their foot and they'll have a short stride on the unaffected side. What are the hip flexors? The major ones are the iliopsoas muscles, meaning the green is the psoas part, meaning it goes from the lesser trochanter on the femur to the lumbar vertebrae. And then the ilial part of it is that sort of clamshell pink lining. The iliopsoas together are the strong hip flexors. The rectus femoris also, one of the quads, is a hip flexor. So you put your right foot in, you also put your right foot out. So extension on the right is the skeleton showing you put your right foot out. Now, the extensor prevents the torso from falling forward when you're standing on that opposite foot. If the extensor is weak, you cannot stabilize. So you have to lean backwards to compensate, like the keep on trucking guy. So the major extenders of the hip are the hamstrings, the semimembranosus, semitendinosus, and the biceps femoris. The third motion is abduction. So remember young Frankenstein, AB normal, not normal, away from normal. The main muscles are the tensor fasciae latae and the minimus and gluteus medius. So these are the AB or away from. They bring the foot away or the leg away. If the abductors, which prevent the torso from falling inward on single leg stance, are weak, you get Trendelenburg sign. That means that the top or the torso has to curve, the hip is tilted away, and so you have this Trendelenburg sign, uh, the torso balancing over that affected side. Ad means towards, so this young man is looking towards the girl, and advertisement makes you want to look towards something. So the big adductors are the brevis longus magnus and the gracilis. If you have weak adductors, you can't prevent the torso from falling outward. So when you walk, you circumduct your leg. The final two movements are external rotation, like the infraspinatus and supraspinatus, rotate the shoulder out. In the pelvis, we have the glute maximus, glute medius, minimus, and all these tiny muscles, including the piriformis on the back of the pelvis, which, as the doctor is demonstrating, show external rotation of the lower leg. Internal rotation is the job of the adductors or the adductors. Now we should talk about femoral acetabular impingement. This is a fancy word for the ball and socket is overgrown, either in a pincher formation, so the socket or the acetabulum is growing in like a pincher, or the cam. So there's like thickening of the neck area where the ball enters. So if you have combined, it's combined FAI. It's idiopathic. No one knows what caused it. Obviously, if we have arthritis, friction, wear, it can cause breakdown. And so you can think of it like bone spurs. It's common in young, active men who have conformational issues, and it causes limitation, pain, and problems. It may be from friction. One of the contributing factors may be anteversion. So on the left, we see the femoral neck and the head should enter the pelvis at a certain angle relative to the tibial plateau in white. If it's too far this way, it's anteverted. If it's too far that way, it's retroverted, causing uneven wear in the socket as shown there and perhaps contributing to FAI. So the hips are a joint, but they're also a region. So the lady grabbing her hip, my hips hurt. Well, it could be you have a hernia, inguinal, indirect, direct. You can have a femoral hernia. It can also be an attachment of one of these muscles onto the pubis that causes pain. I had above that, you see an avulsion of a muscle. I did have a martial artist in Dallas who I treated, and his pain from the adductor attachment to the pubis went away after exosome treatment. So the hips are a region. If the front hurts, it's often, not always, it can be OA of the joint, as shown above. Could be a labral tear of the joint. Could be a femoral neck injury. I did treat one patient who had that clearly on radiographic findings. A lot of times, it's interesting to note that when a person falls and breaks their hip, sometimes they break their hip and fall. In other words, the sequence is muddled. The femoral neck, for whatever reason, osteoporosis is so weak, it just fractures and then they fall and they sometimes don't know which came first. If you have trauma to the tiny artery feeding the head of the femur, you may get aseptic or avascular necrosis. Here's a nifty little fix they can sometimes do to bring in the blood supply from your fibula, the outer lower leg bone, intact and kind of graft it in there to regrow and rescue the head. The region on the side of the hips could be trochanteric bursitis. It could be iliotibial, could be, glute minimus. There's a test called the Ober test. You lie them on their side, lift up their leg, and if the leg doesn't drift down towards the table, it could be tight from this iliotibial band tightness or some other pain from the bursa. The back hurts a lot because of sacral iliac pain. So if you look at the venous dimples on a person, that's roughly from the sacroiliac area up to the skin. And it's a good landmark to see towards the top of the sacrum when you're doing a procedure. The sacroiliac joint is shown in the bony pelvis cartoon. And so below that, the posterior superior iliac spine and the sacroiliac joint, you have the sciatic nerve. Above us, we see piriformis syndrome. If the piriformis external rotator is irritated, it can also irritate the sciatic nerve passing underneath us, causing a sciatica or sort of a pain shooting on the buttocks and back of the leg, foot drop, numbness on the lateral foot. That's not caused by spinal disease. So, one of the contributors to sacroiliac joint pain, just so you know, is limb length discrepancy. We can also have, in the case of lumbar fixation with like Harrington rods or fusion, discectomy, because the lower lumbar spine is immobile, the above and below has to suffer and gets increased wear. Also, joint laxity, collagen vascular disease can play a role. I mean, pregnancy in its last trimester, the relaxin causes all those muscles, the pubic symphysis to separate and the sacroiliac joint to separate. For completeness, we talk about snapping hip, which can be one of two things: the iliopsoas muscle snapping over a bony prominence, or the iliotibial band snapping over the outside bony trochanter. You can also get kind of like snapping, but it's really crepitus in the joint if there's advanced arthritis or you have torn labrum. So it's important to have strong core muscles. So what are these? If you're not walking as I didn't, I bought a scooter when I was in Hawaii. I thought it was so cool to ride around everywhere, to work, to the bakery. So I didn't walk anywhere and my abs and glutes got weak. So what does that mean? The Blue X shows us. When you have weak abdominals and glutes from never walking, you get tight back extensors causing my back pain for the first time in life and tight hip flexors. So you got to be balanced and strong in your core. And that's what a girdle does. It tightens everything up. So when you're not balanced, strong, you can get a sway back, a pelvic tilt. And the lower left diagram shows that instead of using your rectus muscles and your quads and your iliopsoas, your rectus muscles are so weak that you're out of sequence and your pelvis is tilted forward and it can cause spasm and problems. So avoid that. Do your Pilates or whatever. Not to pick on the women, here's a guy with a girdle. So you should have this tight abdominal walls in the front, the rectus, external, internal, transverse. And then you should have these extensors, which are also equally strong, keeping the torso erect, the erector spinae. So we won't belabor this, but yeah, a lot of the problems in the ankles, knees, and hips can be from the flat feet or the hollow foot. So orthotics can be very important. When you get excessive curvature one way, like let's say uh, coxa vera or an acute angle, then you can get a knock knee, right? Genu valgum. And the opposite is true. If you have a oblique femoral neck, coxa valga, you can get genu verum, which is bow legs. Gait disturbances, we won't cover a lot, but a normal gait is balanced. A coxalgic gait is commonly known as a limp. So you can get a coxalgic gait from a splinter in your foot or gout or sprained ankle. If you have Trendelenburg gait, again, that's from the weak abductor. So the torso tilts and the pelvis rises. Horsey gait or Aquinas gait is when you have paralysis of the foot, a foot drop. You might have to lift that foot. Here's that weak hip extender, the keep on trucking walk. There's a Parkinson's gait next to them, which is really poor equilibrium, balance, proprioception, and you can see this little tremor there too. Circumducted gait is shown to my left. A lot of different funky gaits, a lot of different problems people have. So, what's the best thing? An ounce of prevention, as Ben Franklin tells us. Don't overdo it. Don't get injured. Do your conditioning. Keep your core strength. Have good technique. When you do get injured, rest, ice compression, elevation, just to buy time while your body can try to squeeze out the exosomes and repair things. If you want to learn more about exosomes and how they compare with PRP and stem cells and steroids, see tinyurl.com/EXOWEB5. We talk about stem cells, PRP there. The final common pathway is hip replacement. If you have a torn labrum, arthroscopic surgery is just what the doctor ordered to repair. So the total hip is shown here. It's a metal rod going into the shaft, a fake metal neck, a plastic liner, and a metal ball. So we're all headed there if we live enough hundreds of years. In my first book, Telomere Time Bombs, I made the mistake of saying that MSCs become these things. They can in vitro, but in vivo, most people think they don't do that. They just go and release exosomes, causing the local tissue, whatever it be, heart, bone, cartilage, cornea, to de-differentiate, copy, and repair. So why inject it in the hip? We're getting decreased inflammation, hopefully cartilage regeneration, and we'll talk about that in the cases to follow. So know your anatomy above in the pelvis. Look at how much anatomy there is in there. They've got the bladder, the uterus. We got all the vessels. We got the lymphatics, nerves. Don't want to be messing around in this area too much. So we always used to say tiger country is where danger is. Similarly, I don't treat the anterior neck generally. So many things you can go wrong in that area. Posteriorly, we worry about the sciatic nerve. Laterally is pretty safe. Anterior medially, we got to think about navel or the femoral triangle shown above. Navel is for nerve, artery, vein, empty space, and lymphatics. So first thing we do is we're going to draw the anterior superior iliac spine, feel the pubis and draw a line, which is the inguinal ligament. Below that is our triangle, femoral triangle. We will Doppler, see the fast flow in the artery, and make sure we draw with surgical pen the area of tiger country to stay away. So we're lateral to that. We'll find the trochanter, mark it. We'll scan the femoral neck, mark it. We'll find the semi-curved head, we'll mark it. And then we'll make a pen cap impression. We test with our finger to see where we're going, and we'll pass right into the probe and see that nice spinal needle all the way down to the head. Let's talk about four cases. One was AR, a 26-year-old dentist who had fallen from a five-story building. And remember, exosomes are not FDA approved to treat hip problems. He fell in 2019, was effectively dead for 10 minutes. They brought him back to life from the shock and what have you. He had broken both his wrists, so he woke up after a while with hardware. His pelvis was also shattered, so he had to have pelvic fixation. And his spine from T10 to S1, that was his whole lumbar spine, needed hardware. Luckily, he didn't have any TBI, which was great. Unfortunately, several months later, he had a massive infection requiring more fixation up to T8. He had been in rehab with a good improvement, and he had residual gait problems, though, especially on the right. So he's, coxalgic gait, unsteady. In August of 2020, almost a year later, he had just a small dose of 5 billion IB MSC exosomes. For 4 weeks, he said nothing was happening, but week 5, the pain in his back went from an 8 to a 4, and the wrist went from a 6 to a 3. And more importantly, he and his therapist both noted that his right leg strength and his gait were much improved, 70% improved. So again, we didn't put it in the area where it was needed. There wasn't any inflammation, so there wasn't any homing to the area, but enough of it got in his system to get to the OSIS compartments, the incompletely healed compartments. And by 5 weeks, he was much better off. Case two is a good friend of mine. Our sons were born the very same day, 25 years ago. And so this man had had pins in his hip as a teenager. And then at age 49, he finally gave in and got a hip replacement. During that multi-hour surgery, as you can see next to me, the retractors are pulling stuff apart so the surgeon can work. He had chronic hip pain from that surgery. It was just below the iliac crest, so we figured out it was probably the glute medius. Injected the glute medius along with his shoulder and his back, and his pain resolved in hours to days and is still good years later. Third patient, JE, 28-year-old I met a few months ago when I was treating his dad to try and help with his spasmodic dysphonia, which RFK Jr. has. So starting age 20, he had a flare of gut dysbiosis, leaky gut, mast cell activation. Who knows? It was maybe he got a Gardasil vaccine. I don't know. But at that time, his hips started hurting a lot. So the pain is always worse after exercise. Luckily, the doctor outside of New York was able to help with naturopathic methods. It did leave him with some hip problems. He tried PRP and stem cells in 2019, didn't much help. And as recently as June 2024, he's a very active guy. He works out, does a lot of exercise and sports. It showed the MRI with right greater than left bilateral CAM type FAI. So a couple of months later, we were treating his dad, so we treated him, and his pain has greatly improved. We did ultrasound guided hip injections, and you can see there that the CAM deformity. A CAM is a mechanical term for something that takes linear, or I'm sorry, rotational movement and makes into linear movement. So like a cam in the pistons. So they call it cam because it's not round anymore. It's kind of oval, I guess. The fourth case is JB, someone I've known for probably over 8 years. She took TA65 and then a recharge and now TA65. She swims an hour a day for 4 days a week, walks her dog an hour, does 2 hours of gym work every day. Very dedicated master's athlete. She had tried PRP 4 years prior when it was diagnosed that she had a torn labrum. It didn't much help, but it was enough to keep her going. But in the last 3 months, her pain just got really bad. She was considering replacement, but she knew about my work. So she came in. We did an ultrasound guided injection. Within 1 week, the pain was better. And it's been fine, asymptomatic for 2 years. So much so that, as I said, she is a patient for life. She did her wrists and knees, also improved after injection. So we won't go over every point, but the salient parts are that you can download this protocol if you're a member of the course. Also, I will upload a video of a live hip injection. This slide above, which is not mine, basically shows it's a very easy procedure. This a few things that I'll do only with ultrasound. Specific nerve injections, facet joints, maybe the quadratus lumborum, maybe specific muscles. Otherwise you can kind of just feel your way around, know where the anatomy is. You don't really need an ultrasound, especially for the shoulders and hips. It really adds very little, in my opinion. So, main points: why do we do this? Osteoarthritis, labral tears, avascular necrosis, FAI, probably. Contraindications: active, untreated viral cancer. If we have recent hip surgery, we want that sterilizing effect. So, I wouldn't do it before 10 days. The supplies are shown there. The goal is to scan, mark with surgical pen in a supine non-frog leg because I don't want that movement. And then we just find the pathway by palpating. Imagine where it's going to go in plane under the probe. We betadine prep at the pen cap site where the needle will enter, and you'll be passing through the rectus femoris, and you'll be passing through the iliopsoas. If you use a tiny 27 gauge 1.25 needle, you can numb most of that. Patients don't really feel it. So they love watching it, and it's really a cool procedure. So that's about it for hips. Oftentimes, people say it's the hip, it's really the sacroiliac, it's really the IT band or bursa, it's the piriformis. So again, it's up to you to figure out why that woman is clutching her hips. Sometimes patients aren't sure, they don't know, but all the clues are there. So thanks for watching. If you liked it, please like and share, subscribe, and hit that notification bell. I'm DRPARK65 on YouTube. Also, I send out weekly newsletters with interesting cases and announcements. So sign up for that at rechargebiomedical.com. Next week, if all goes well, I'll be back from Dubai and we'll be talking about back problems with an emphasis on the lumbar epidural injection, but also other types of back injections and pathology. So, also, if you like and you have a commute, you can download my audiobook, Exosome Songs of Healing, which is essentially the same as the print and the ebook. All right, everybody. Thanks a lot for attending. We'll see you hopefully next week.